Audio Jungle.
Hi everyone, a very good evening to all of you. I hope your Sunday is going good. Now is the evening session of DRDCA 2020 and second week has started. This is uh, today four speakers were with us. We finished the morning session on a very good note. We learned about dental genetics. We learned about compassion in dentistry. The speakers were Dr. Gaji Roy, Dr. Dr. Gaji and Dr. Jagdish. I myself am Dr. Pallavi Mahajan, an endodontist, a writer, an artist, and all the scientific sessions in DRDCA 2020. For those who have not registered for the conference, kindly do so by downloading the app and registering yourself for DRDCA, details of which you will get on DRDCA FB page or you can contact any one of us. So guys, BB King said that the beautiful thing about learning is nobody can take it away from you. So on that note, let me tell you about the next speaker that we have on board with us. The speaker's name is Dr. Rishikesh Bhaumik. He is joining us from Bengaluru. Dr. Rishikesh has done his master's in oral surgery, followed by a fellowship in craniomaxillofacial surgery, FCMFS from Mazumdar Shaw Medical Center, Bengaluru. He is a visiting consultant, oral and maxillofacial surgeon at Manipal Hospital, Whitefield. He is a chief consultant, cleft and craniofacial surgeon at Coorg Institute of Dental Sciences. Now, we often manage pediatric patients in a dental clinic, right? But have you ever treated a child with a cranial defect? A child with craniosynostosis? Have you ever heard that a titanium implant can be placed in cranium? I have not, and therefore I'm looking forward to this session. Dr. Rishikesh shall be discussing his experience with pediatric craniosynostosis cases and the general protocol followed in the hospital. Also, the use of cost-effective patient-specific titanium implants in his Institute for Managing Cranial Defects. Now, without wasting any more time, I welcome Dr. Rishikesh on screen. Dr. Rishikesh Bhaumik's screen is yours. A very good evening, sir.
Good evening, doctor. Thank you so much for the introduction. So without any further delay, I think I should start on with the presentation. Is my screen visible there?
Yes, very much visible.
So greetings to one and all gathered here today. My name is Dr. Rishikesh. I'm a consultant craniofacial surgeon in Bangalore. My topic is actually I've divided into two parts. The first part I'll be talking about pediatric craniosynostoses, and in the second part I'll be talking about how we deal with adult cranial defects. Now, craniosynostosis is basically a congenital disorder that occurs due to premature fusion of the sutures of the calvarium. The reported incidence of this sort of an anomaly is 1 in 2000 births worldwide. More than 300 syndromes have been associated with this disorder. However, most cases can also be non-syndromic. Craniosynostosis is a pathological disorder of varying complexity that can have a profound and lifelong effect on the neurocognitive development and appearance of an individual. So, the ideal treatment for correction of this kind of a disorder depends on the age, the location, the number of sutures involved, the skill sets and philosophies of the treating teams. While no single treatment is considered to be the best, but surgeons today can choose from various options that are available. There is no consensus that exists regarding the timing of surgery in the presence of signs and symptoms of raised intracranial pressure. We choose to operate on an urgent basis. The goal of any kind of surgical intervention is to provide adequate intracranial volume to allow the development of the brain and to create an aesthetic skull shape. This can be followed on later by secondary corrections to both the calvarium and the midface as and when required. The standard method of treating craniosynostoses involves extensive cranial vault and cranioorbital recontouring surgery. Many different techniques and modifications exist. These techniques depend on the surgeon's preference and experience alone. There is no standardized algorithm. Each case requires individual attention and decision making. In the end, the treatment relies heavily on the surgeon's subjective perception and artistic vision. So now a question arises, how do we make these surgeries more objective? Now, computer-assisted surgeries have been gaining credibility to achieve objective and precise correction of craniosynostosis. One such latest advancement is the virtual surgery using CAD/CAM techniques to create prefabricated templates for planning osteotomies and placement of bone segments. Although these are very accurate, these techniques have their own drawbacks in terms of cost, time, and resources. Also, the learning curve is steep. So adopting such a prototype methodologies may not be feasible in the current Indian scenario. Taking all these factors into account, we at Mazumdar Shaw Hospital developed a comprehensive protocol for the management of craniosynostosis. So our protocol follows a very simple stepladder pattern in a sequential manner. In this protocol, we explain a comprehensive, simple, reproducible approach towards a patient with craniosynostosis. The ultimate goal of this protocol is to provide a cost-effective, reliable, simple, and objective treatment strategy, which complements the surgeon's subjective vision. I'll be taking you through all of these steps of our protocol in detail. Starts with, of course, history taking and assessment. Now, the initial part of the protocol is very simple and straightforward, which is routine for any kind of congenital anomaly. A multidisciplinary assessment is carried out involving neurology, neurosurgery, ophthalmology, genetics, and pediatrics. So we need to identify if at all there is any syndrome associated along with the craniosynostosis. Sometimes there will be presence of clefts. Sometimes there will be other anomalies. Raised intracranial tension is one of a major concern. There could be visual disturbances. And also we need to counsel the parents of the patient psychologically. The next step involves morphometric cranial measurements as described by Farkas. So we measure the head width, forehead width, head height, head length, head circumference. We do this pre-operatively and also post-operatively along with each time the patient comes back to us for a follow-up. So these measurements help in documentation for future comparison and for comparison with the corresponding measurements in normal individuals. A simple way of fabricating a three-dimensional cranial model is by what we call as moulage. So basically, the moulage is nothing but an impression of the cranium. So all we need for this is our very favorite alginate impression material and some plaster of Paris soaked gauze. So we carry out the procedure when the patient is sedated before a CT scan. So the first stage is cranial impression, and the second stage is the orbital impression. Of course, we have to cover the eyes with tegaderm. And finally, the entire impression is removed as a single unit and poured using dental stone. Now, care needs to be taken that the entire orbits are included, including the inferior orbital rims in the impression. This helps in planning out the fronto-orbital unit. Now, what is the fronto-orbital unit? You'll get to know in the next slide. So here we can appreciate the reproduction of the deformity. Now, the advantages of a moulage, basically a model, is it gives us a handy 3D model to orient the surgeon and the team. We can draw the proposed bony cuts on this before we actually go in for the surgery. We can adapt modeling wax to replicate the bony cuts, and also we can prepare in-house osteotomy guides using our basic cold cure acrylic. It can be used to educate the parents, and it can be used to fabricate custom-made post-operative orthotic device. Basically, orthotic device is a helmet that we use post-surgically, which I'm going to be talking about later. And also, it can be used as a treatment record. The next step is a CT scan. This is a very important thing that we do for all of our patients. We do basically a CT scan with a 3D reconstruction. Now, Weitzman in his article has given a detailed normal head measurements of children right from the time of birth to adolescence with all the standard deviations. So we make linear measurements on the axial sections of these CT scans. We also include a few more landmarks on the axial section, including the glabella, the supraorbital, and to create a frontoorbital curve. Now, I shall be discussing the importance of the frontoorbital curve in the next slides. We can also use a software called as 3D Dolphin to make to get all these measurements, but which is not an integral part of our protocol. We can also do without using the software. Now, this is what we call as the frontoorbital unit. So this frontoorbital unit is marked on the moulage. Modeling wax is adapted over it, and this is analogous to the frontoorbital unit, which is to be osteotomized during the surgery. Now, the next thing is that patient's frontoorbital contour, which we have generated from the CT scan, is transferred onto a graft sheet. So the wax frontoorbital unit corresponds to the patient's frontoorbital contour. Here we describe our method of objectively deciding the required contour. We have generated and documented age-matched database for of average frontoorbital contours using already mentioned landmarks on the CT scans of normal individuals. Now we extrapolate the data onto the same graph sheet, which shows us the discrepancy and also the required contour change. Now the same frontoorbital wax sheet is recontoured to the new position, which reflects our intraoperative goal. The rest of the frontoparietal bone can be recontoured using various techniques. One of them that we most commonly use is the bone flip technique. So basically, we cut the frontoparietal bone flap into half, and we flip it on either side. And the further adjustments can be made intraoperatively by using technique called as barrel staving or curving, etc. So here you can actually see the kind of advancement that we have done and we hope to achieve intraoperatively in the patient. So we reorient the wax sheet over the moulage, which gives us an idea of the intended cranial shape that we want to achieve, which is basically our intraoperative goal. This provides a visual comprehension of what needs to be undertaken and gives us an orientation. This detailed front-end preoperative works leads to increased efficiency in the operating room and may eventually lead to decreased operating time due to the elimination of any guesswork. So surgical time is not expended in trying to figure out and identify the best fit of the calvaria grafts. So we'll quickly run through a few intraoperative images. This is the patient's skull, basically, and we use a standard bicoronal flap using a wavy incision, and the osteotomy is performed to raise the frontoparietal bone flap. As we have seen the model before, the same thing is being reproduced here on the patient. Here, the next step is to separate the frontoorbital unit, as we can appreciate in this picture. So this frontoorbital unit is also called as the frontoorbital bender. The same thing. Now comes the actual extrapolation of the 2D contour analysis that we had done in the beginning. So the frontoorbital bando is shaped to assume the pre-decided frontoorbital contour. A simple malleable brain retractor can be used, which is bent as per the requirement, and is used in our intraoperative template for guiding the surgeon in achieving the desired shape. So in contrast to the prefabricated rigid templates that are being used in some countries, our technique always allows for minor changes and overcorrection as the surgeon deems necessary. Now this slide shows the frontoparietal flap and the frontoorbital bando in place in their final position. We can use resorbable bone plates here, or we can also use basically sutures to stabilize the replaced bone segments. Here we show you a few treated cases with pre-op and post-op cranial morphology, and this is a patient with a condition called as trigonocephaly, basically where the cranium looks like a triangle. It is caused due to the fusion of the mitopic cranial suture before that. So here we can see 1 month post-operative change. We can use our technique on our protocol to suit a variety of different kind of cases to generate consistent results. I'm just going to run through a few cases so that you can visualize the difference. This is another case of a trigonocephaly, which is basically roughly about 20 days post surgery. You can appreciate the difference in the the change in the morphology of the skull of the patient. Now coming to the cranial orthotics. Basically, orthotics is something like a helmet that we design to guide the skull shape post surgically, because when we do the surgery, we actually create gaps in between in the cranial bones. So if we do not provide an external guidance to it, sometimes the bone gaps may prematurely close or collapse. So basically, the brain, when it grows, it kind of provides a intrinsic distraction forces, which which is like a propulsive force which guides the growth of the skull. Now, without an external guiding orthotic device, the expansion can occur in any direction, and probably sometimes in the wrong direction, and the surgically done correction could be less complete. Now, owing to the positional impact post-surgery during when the patient sleeps, we felt a need to support the posterior cranial vault without causing a premature filling of the bone gaps. So our protocol provides an excellent preoperative objective data that can be effectively used in planning and execution of this surgery. Preoperative planning always results in reduced operating time. The template that we create using a malleable brain retractor also proves to be a cost-effective alternative in determining the frontoorbital contour intraoperatively. Our technique allows reproducible objective results that improve outcomes regardless of the expertise of the surgeon. Currently, research is also going on in delineating the molecular pathways governing the premature sutural fusion. There are researches which is going on using QRT-PCR and microarray analysis to identify the dysregulated genes. So we intend to expand the available knowledge on this topic and create targeted gene therapy for preventing premature sutural fusion, which can be used as an adjuvant to surgery in the future. Now, coming to the second part of my topic, which is how we deal with post-traumatic adult cranial defects. Now, in our times, neurosurgical procedures are very commonly performed on patients with head injuries after road traffic accidents, falls, or assaults, or after tumor resections. Now, neurosurgeons usually try to preserve the cranial bone flap whenever possible, inside the abdomen sometimes, for later use to cover the cranial defect that is formed after the surgery. But sometimes these preserved bone flaps end up necrosed or devitalized and either unfit for use or need to be removed. In such cases, these patients end up with a variety of cranial defects, such as these or these, or sometimes more subtle ones like this. So these kind of scenarios are quite commonly observed. These defects, we should always remember that these defects are three-dimensional. These are not flat defect. These are a three-dimensional defect, and it needs to be reconstructed, not only for aesthetic purposes, but also for the protection of the vulnerable brain, which is lying just underneath the scalp tissue. So an ideal cranioplasty material must have the following features, like, it should fit the entire cranial defect and achieve complete closure. It should be radiolucent. It should be resistant to infection. It should not dilate or change its shape with heat. It should be very strong. It should be, again, easy to shape, should not be expensive, and ready to use at any time. But then, even after all this, we do not the ideal material does not exist, right? No material would actually fit all these criteria. Now, there are many materials that have been used in the past for cranioplasty. Many of these materials mentioned here are not really used anymore, and some of them are of historical importance. I'm not going to discuss all the pros and cons of each of these materials in detail. I'm just going to go through what we use in our hospital. Basically, it's what we use is titanium. Titanium specific implants are our material of choice because it ticks most of the boxes for us. It is rigid. Titanium is rigid but lightweight. It is relatively cheaper and easily available. In the next slides, I will show you how we fabricate these implants. Of course, we use a very good outsourced laboratory for this purpose. So these are the various steps that are involved in manufacturing of the implant. So first of all, what we need to do is get a fine cut CT scan of the skull along with the defect. So we prefer CT scans with minimum 0.5 to 0.6 millimeter slice thickness. Because that sort of a fine cut CT helps us achieve a very good quality STL model, stereolithographic model. If the cuts of the CT scan become thicker, the STL model tends to become more distorted. So we always prefer 0.5 to 0.6 millimeter cuts. So once we have the STL model with us, we go on with doing something called as the wax up. Basically, we use our favorite modeling wax to build up the defect, and then once we have achieved satisfactory wax up, we send it to our lab for fabrication of the titanium implant by a technique called as SLM. Now, what is SLM? If you ask, it's basically selective laser melting, which is a type of rapid prototyping system. Basically, what they do is they have titanium powder, which they melt it using a very high-powered laser and shape it in form of the implant. This is how the STL model looks. We all know what is an STL model, I think. We have used here our regular dental modeling wax to recreate the shape of the lost bone segment. Now, it is not only important to cover the defect, but it is also important to give the natural contours of the lost bone segment. So here, knowledge of anatomy is of very much it's important, so that we can create a proper implant. Once the wax up is complete, we send it to the lab for further fabrication of the implant. Now, this is what the implant looks like. Basically, this is the final product. So you can probably appreciate the contours here. It is not a flat implant, but it has contours. It is a three-dimensional shape. Now let's just run through a few surgical photographs for a better understanding. So here is a patient who has this skull defect reconstructed using his own bone flap. Now, as I said earlier, sometimes these bone flaps, they become non-vital, okay, and they become resorbed. Sometimes they don't work anymore. So unfortunately in this patient, it had to be the his bone flap had resorbed and had to be removed. So we reconstructed this defect using our own titanium patient specific implant. So this is how it looks basically. So let's run through a few other patient photographs. Now, if you remember one of the previous slides, I had shown you this patient. So he had a very bad frontal bone defect, and we used the same technique. We used a similar titanium implant for him, and this is an immediate post-operative picture showing the restoration of the lost contour. Of course, there is some edema present, but within a few days, this edema would subside and the patient would look more normal, if you say. Here is another lady who had a tumor resection surgery. She was completely fit otherwise, free of disease, but she had this sort of a skull defect, and she wanted to get married and move ahead in life. So we placed an implant for her, similar sort of an implant, and this is how she looks 1 month post surgery. So that's all I have for you. I hope my topic would have excited or inspired some of the budding surgeons and undergraduates who are here in the audience. I would like to thank my mentor, Dr. Paul Salens of Mazumdar Shaw Medical Center, under whose guidance I have had the opportunity to learn these techniques, these surgeries. And also, I would like to thank the amazing neurosurgery team in our hospital, without whose support these surgeries would never have been possible. Finally, I thank you for your patient hearing.
Interesting for me to know that these things do exist. Like, no, there's Dr. Nupur in the audience who has written that it is mind blowing what oral surgeons are capable of doing. I think that is so true. Uh, so thanks for sharing these cases and thanks for taking up this topic. And showing some light on it, throwing some light on it. I had one question. I think there's no question as such from audience, sir, but I wanted to ask you something. Are there any post-operative complications or anything like that that you have seen in these cases?
Which one are you talking about? The adult
Sir,
patient?
whatever surgeries.
See, any kind of surgery can have potential complications, of course. These are not small surgeries that we are doing, that we
Right.
deal with brain and stuff. But in the craniosynostosis patients that I have shown you, we have hardly ever faced any kind of really bad complication that you're talking about. Of course, there will be post-operative edema, a lot of swelling. Patients' eyes will be shut off for the next 2 days. That kind of a swelling we are talking about. Of course, parents have to be counseled before that. When they see the child like that, they are usually
Right.
very scared, because
Right.
the eyes will be completely swollen and shut for the next probably 2 days. But then usually after third day onwards, the swelling, everything starts subsiding, and I think I've shown you pictures 15 days post-op also, right? So There are, of course, theoretically, there are a lot of possibilities of complications, but we have not encountered any major complications so far.
Okay. Okay.
Of course, when you talk about these implants that the cranial implants that I have shown you, in any kind of implants, be it dental implant, also you can have a complication. You can have
Right.
infection, right? You
Right.
can have bad infections. You can have abscesses and stuff. Sometimes there is also a possibility of the implant getting rejected. Although it's titanium, it is highly biocompatible. That's the reason we use titanium in so many things. But sometimes it is possible for the body to reject it also.
Okay, sir.
Right?
Okay.
In one patient, we had actually that was not the complication associated with the implant per se, but the patient had a recurrence of tumor,
Oh,
because of which we had to remove the titanium implant and he had to undergo another surgery and things like that.
question, sir. How do you decide surgery or prosthesis?
I did not really understand the question.
Even I did not understand completely. Um,
Um, can you be more specific? What you
so,
really want?
whoever is okay. Do you refer? And this is another question. Do you refer patients to maxillofacial prosthodontists later?
No, not really.
Okay.
No. So the thing is, we fabricate the things that we showed you here. This wax up and all those things are done by us.
Okay.
We used to do it when we were fellows, of course, and when the new fellows join, they do this. So you need to have a very good, decent knowledge of anatomy
Okay.
to do the wax up. Now, what you exactly make in the wax up is what is fabricated by the lab, right? So you have to give them that. The lab is not going to do it for you. The wax up is done by us,
Okay.
right? So we have to create all the contours that are lost. So you have to understand the skull is not like exact sphere, right? So it has its own contours in places. So you need to know the anatomy of the bones.
Okay. Um, Customized titanium implant. How is it fabricated?
Yeah, so basically, like I told you, we have to take a fresh CT scan of the patient. Now, the CT scan has to be very fine. Why fine? Because we need a very accurate STL model, a stereolithographic model, right? So we usually we basically always prefer 0.5 to 0.6 millimeter fine cut CT scans for this purpose. Now, once the STL model is prepared, what we do is the wax up. Now, as I showed you in the pictures. Now, this wax up, once it is done, we send it to a lab. Now, this lab manufactures these kind of titanium implants using a method called as SLM. Basically, it's a type of rapid prototyping where they melt, powdered titanium, using laser or whatever, and they prepare this sort of implant.
Okay, sir. A question. One more question, sir. Is there a risk of relapse?
Risk of relapse.
Right.
See, this is relapse as in, see, this is a titanium implant. Okay, this is not going to deform,
Right.
right? Uh, as I showed you in one of the pictures, I think if you remember, there was a bone flap, the patient's own bone flap, which is placed back to cover the defect, right?
Yes. Yes.
So in that, what happened, unfortunately, is the bone flap itself, it got resorbed and necrosed, and it was not holding its shape. So that is what is called as a relapse.
Hmm.
So what we did was we removed that bone flap and replaced it with titanium. So now titanium is not going to deform.
It can happen in autografts, maybe.
Yeah, you can say so. Autographs, they can resorb, they can, things like that. It can relapse in that way. Yeah.
Right, sir. So, what is the cost of this surgery?
See, cost. There's no particular amount that I can tell you like that. It depends on the defect, right? There could be various kinds of defects. Assessment is required. According to the size of the defect, the cost of the implant varies. According to the size of the defect, the cost of your STL model also will vary. So it's variable. It's
Right.
not.
For example, so if a patient comes to me in my practice and I see that some defect is there and I suggest the surgery, but sometimes the patient first question is, "Ki ma'am, kitne ka padega?" How much? So
Right.
what do we suggest? Like go and they'll check it there. Yeah, thoda estimate we can give.
We can only give the estimate after assessing the patient. So
Okay.
you have to understand that there are, this is not like a one day thing that is going on. So
Right.
once we see the patient, it takes some time for us to, do the wax up and, send it to the lab, get the implant. And then when the surgery, when we do the surgery, it involves both us and the neurosurgeons.
Right.
So two team approach, right? So that way the cost of the surgery could be variable. So I cannot comment on that really.
So last two questions. One is that who mills these implants in India? Is there any particular company or anything that we can? Uh,
There is a company, there's a lab that we there are actually many labs which do this.
okay.
The one we send to is in Kerala, the
Yes.
particular lab which does this job for us.
Okay, sir. Final question, sir. Any courses that you can suggest and how to get trained in this field? I think some students asking that.
Yeah, so basically how I joined Mazumdar Shaw Hospital was you have to give an exam, right? You have to clear that exam and your interview, and then that is how you join basically. There is also a craniofacial center in Kerala, in Amrita Institute of Medical Sciences. There also you can get trained.
Okay, Dr. Rishikesh, these were the questions. Thank you so much for a very, I think, different and interesting topic. Definitely a trigger would have, somewhere people are thinking about it now. So
But they
students
should.
are thinking. Yes, they should. Thank you so much, sir. It was nice having you. It was like an honor for us. Thank you.
Thank you for having me. Thank you.
Thank you, sir. Thanks a lot.
Thanks. Bye.
Bye. So that was Dr. Rishikesh Bhomik for with us and uh, Craniosynostoses. Honestly, I did not know that much about this topic, and uh, simple fact that these surgeries are being done, it can open up so many options for people who, their physician or dentist that you suggest us or we, whatever should be done. We can guide them properly at least. Now, next speaker with us is joining us from Uruguay, uh, Dr. Carolina Benitez. She's a laser dentist practicing in Uruguay. She's a postgraduate from Uruguay Catholic University, Master Laser Therapy in Dentistry, Laser Safety Officer for RWTH Aachen University, Germany, AALZ Aachen Dental Laser Center. I'm really sorry for all the noises you might be hearing. RWTH Aachen University and World Academy for Laser Education in Dentistry. Dr. Carolina is the representative of the ALS Germany for Uruguay. Now, she's going to speak about lasers in endo, right? So we have heard, being an endodontist, even I have heard about lasers. I have used also in one of the patients. Uh, my introduction to laser was like, I think a big, first we read it, of course, in our books. And then there was a long question in our final year exams, lasers in endo. So we all know that laser has its application while doing root canal treatment, but how sure we are about the repercussions or maybe the result, especially when it's compared with conventional root canal treatment. Like, is there any difference? Is there no difference? What does studies say? We all know what we tend to do. We don't read out those many studies. So yes, Dr. Carolina today is going to prove whether laser improves our endodontic treatments or not using a microbiological control. We are waiting for Dr. Carolina to join in. And till then, let me tell you something about app. If you have not registered yet, do download the app. Dr. Carolina is about to join in next 5 minutes. But you guys, till then, if you have not registered, uh, download the Eventi app and register yourself for DRDCA 20. There are some cultural competitions also that are going on. So till 10th of November, you can send your entry. Wherein, if you are interested, like other than dentistry, if you are passionate about dancing, singing, writing, poetry, anything else, you can send in your entry and you might be awarded. Another thing that is there is lucky draw. So one lucky person will get this Novolace laser therapy machine. How I wish I could be that person. So yes, one lucky person will get this. What you need to do is you have to same thing. You have to download the app. You have to register yourself. Then you have to take part in the scientific sessions that we are doing. Basically, you can ask questions. You can tag your friends. You can let them know about the conference. You can share it on Facebook, on YouTube, or YouTube link also you can share. Another thing that you have to do is you have to take part in one of the cultural competitions that I mentioned. Please go on the website, go on DRDC FB page, and you'll get all the details. After doing all these things, you have to take screenshots just as a matter of proof, you can say, and then send it to us over email. All the lectures, all the scientific sessions that we are doing here throughout the month of November, most of them will be available on YouTube and DRDC FB page along with app. So you are free to revisit them anytime. In the app, all the speakers have their details mentioned, their email ID. Some of them have even given their phone numbers. Feel free to connect with them. Also, in the morning, we have Dr. Gargi with us. She mentioned about an international symposium on saliva that is going to take place in January somewhere, in January end, I guess, 2021. So you can contact her and get to know more about genetics, role of genetics. Dr. Jagdishan was there in the morning and he talked about comprehensive treatment planning. Yesterday was an endo day. So in short, we are covering slowly all the aspects of dentistry. We are going to cover little more and more and more. Any questions that you have, you can put it in the comment section below and on the side. And now let me tell you something about myself, because we have some time. The session is about to start. So let me introduce myself properly. I think I did not get that much time to introduce myself. So I myself am Dr. Pallavi Mahajan. People who are joining me listening to me for the first time, I'm an endodontist, a writer, spoken word artist. So basically what I do is I write in Hindustani language, poetry in Hindustani language, and I recite it on stage in events. So Hindustani language is a mixture basically of Hindi and Urdu language. So, but today, since we have an audience from all over the world, I have something to share with you. Let me see if I have it. We all know you all must be aware of a writer called Robert Frost. Robert Frost. Okay, so he was an American writer, and a wonderful poem that he wrote. He was born in the poem was all about taking the road less traveled by, and that's what we are doing. I think today's session, all the speakers are talking about the topics that not every speaker speaks about and all those things. So see, we have Technical glitches again, guys. I'm really sorry. There is some technical glitch that is happening, and
My beautiful journey in this science started as early as 2006. I remember I was treating a 40-day-old baby and I had to take a laser unit on rent for 350 rupees from an ophthalmologist in my small town. It is that day that I realized that majority of the Indian dentists do not know how to use a laser, primarily because they cannot own one, they cannot afford one. I find Ratan Tata's work and life so very inspiring. He was the one who made us believe that as Indians we can do great on the international scene. He was the one who made me believe that poverty is not a handicap, but a poor mindset definitely is. He was the one who made the dream of every Indian to own a car possible. Similarly, Novoles, which was actually conceptualized and born as early as 2006, wants to make laser dentistry affordable to every Indian dentist. So with Novoles, we can proudly say that laser dentistry is no longer expensive, but the ignorance about its possibilities and what it can do for majority of the doctors and dentists who use it, and for the majority of the patients on whom it will be used, that we are trying to reduce the cost of that ignorance and make it very affordable. People call me an entrepreneur, people call me a laserpreneur, but I want to call myself a peoplepreneur because I work for the people. Novoles as a brand is different because we strive to make a difference to the lives of all the people who touch our products. We want to alleviate and ameliorate the pain and sufferings of millions of Indian patients. That is possible only when majority of our dentists get to own a laser, get to work with a laser. Our USP lies in the fact that today every Indian dentist can own a laser for as little as ₹1,00,000, even less than ₹1,00,000. So the concept behind Novoles is Indian, the design behind Novoles is Indian, but the execution is happening in a German console. So that makes it India's first truly international laser. Post-COVID-19, a lot of my friends, fellow colleagues, brothers and sisters in the dental fraternity are worried about their future. They are insecure. They are not sure as to what's in store for us. Well, this is my 16th year in this profession, and let me share something very interesting. The number one reason that kills dental careers is not the lack of degrees, experience, or the lack of patience. It is the lack of exclusivity. With laser dentistry, you can get that exclusive touch to your practice. With Novoles, you can think beyond the root canals and the crowns. You can think beyond the oral cavity and the head and neck. This is your best chance to be a laserpreneur. COVID-19 is neither the first pandemic that we are facing, nor will it be the last. So my Guru Mantra for all of you for the day is that uncertainty is the new certainty. Let's stop complaining. Let's upskill. Let's evolve. Let's conquer. Jai Hind.
Hi everyone. I am audible and everything is fine. There was this delay. I'm really sorry. And before the technical thing happens again, let me quickly tell you about Dr. Carolina and call her on stage. Dr. Carolina Benitez, a laser dentist practicing in Uruguay, is with us.
She is a postgraduate from Uruguay Catholic University, Master Laser Therapy in Dentistry. She is a Laser Safety Officer for RWTH Aachen University, Germany, AALZ Aachen Dental Laser Center, RWTH Aachen University, and World Academy for Laser Education in Dentistry. She is the representative of AALZ Germany for Uruguay. She'll be talking about lasers in endo. Without wasting any more time, let me welcome Dr. Carolina Benitez. Ma'am, screen is yours, and I'm apologetic about the delay and everything. Yes, ma'am.
Thank you very much. Okay.
Yes, ma'am, we are ready.
Hay que sacar el chat.
Yes, ma'am, we can hear you and we can see you also very clearly.
Ma'am, you can start your presentation. You can start your presentation, ma'am.
¿Qué me está diciendo? Yes, good again.
You can start the presentation, ma'am.
My presentation.
Yes, ma'am.
Share my oral presentation. Yes, my lecture. Yes. Wait second, please. No. Start the presentation.
Yes, ma'am, we can see it.
Thank you very much for introduction. I want to thank DRDCA 2020 International Congress for invitation and the whole organization and team. For me, it's a pleasure to collaborate and help with the DRDCA 2020. It's an honor to collaborate from my country, Uruguay, for India, and especially thanks to my mentors in laser, Professor Dr. Norbert Goodnet, the Germany, René Franzen, the Germany, and Professor Dr. Pilar Martin, the Spain, and Miguel Martin, the Portugal, from RWTH Aachen University, Germany, and Wallet and ALZ, World Academy for Laser Education in Dentistry, and Aachen Dental Laser Center. My special greeting to ALDIA, Ibero-American and Laser Dentistry, to all my colleagues and work in these years for pandemic, from the different colleagues, the different countries, the audience, of course, sure. Comparative study on the odontic treatment with a laser with microbiological control. In this slide, they show the RWTH Aachen University, Germany, and AL Aachen Dental Laser Center, and the World Academic Education in Dentistry. This is the campus, the Germany. It's beautiful because a lot of green is in the Aachen. Aachen is the small city, but it's very beautiful in Germany, the city. So this is the Professor Norbert Goodnet, the director of the Aachen Dental Laser Center and the World Academic for Laser Education in Dentistry. This picture is in Mexico, and this is Pilar Martin, the Spain, and other colleagues, René Franzen, and other colleagues, the Mexico. So I introduced my country. Uruguay is a small country, but a beautiful country. I live in Montevideo, yes, is a natural country and different place in Montevideo. I live in Montevideo, but I'm born in another city, the name Young. This is the introduce my country, Punta del Este. In Uruguay is the most beautiful beach and important in Latin America. Yes, and have a lot of beach, green, and showing with the family and families and friends. This is a culture very important in Uruguay, in Latin America. The fingers, the names, and the immersing the sand. So, introduction. This communication will review the importance and complications of the microbiological control in endodontic treatment and the role of laser system and the optimization of disinfections. The elimination of pathogenic microflora from the root canal during the endodontic treatment is one of the main goals of the endodontic treatment. We know that the apical cells, the canal system, is very difficult area to disinfect, and we present our laser treatment concept with 3 well-ones in order to improve the microbiological control, because we can work in different chromophores and tissues where area disinfecting different microorganisms. According to Professor Dr. Norbert Gutnet, the Aachen Dental Laser Center and the Aachen University, Germany, the bacterial contamination in the root canal can produce a lot of problems: periapical CECT, periapical granuloma, and bone resorption. Side effect of lasers versus conventional irrigator. The incorporation of laser activity irrigation in the endodontic treatment will play a significant role in the management of root canal system disinfection, comparing conventional irrigator like sodium hypochlorite versus lasers. Our research, our work. This work supports my friends and colleagues. Another college, the Spain in this moment, travel to Uruguay and Spain, Spain and Uruguay. Our aim in this presentation is to prove whether only laser improve disinfection in the endodontic treatment without sodium hypochlorite. Using a microbiological control and Streptococcus mutant and Enterococcus fecalis. This is bacteria, Enterococcus fecalis, in the endodontic treatment is very important, very problem in the treatment. Using a microbiological control, we can know if they have better decontamination while avoid the side effect of this irrigator. And clinical study in this work with Pilar Martin in Spain, and calibration the different well-ones. Yes, in this pitch calibration, the 940 nanometers, the lasers, and work in the hands, yes, 2,790 nanometers, and this is the laboratory. Work, this is the slice work, the 660 nanometers, and work in the hands, different tools, yes, and 2,790 nanometers work in the hands. Collaborate in this work the University of La Laguna, the Canarial Island, and other professor, very important, this Professor Basilio Valladares in Spain. And the team, material and methods materials and methods. Clinical study. The patient included in the study are divided in 3 groups. Group 1, 5 patients under treatment no laser. Group 2, full tissue for future research. Group 3, 5 patients with endo treatment laser. Group 2, the pulp tissue for future research. In this year stopped because for pandemic is very difficult around the world and no work in this moment for this research. Clinical study, yes. In the clinical study, use the clinical history, periapical X-ray before and after, photographic study, diagnosis, microbiological studies, Streptococcus mutans, Streptococcus fecalis, visual analogous scale, and evaluation the patient experience, the pain and comfort, and the visual analogous scale, the 0 for 10. Yes. Okay, so radiographic study. We use a different imaging system. Yes, there are, of course, periapical, periapical and OPT and micro CT applied to endodontic. It's very important because in endodontic is very difficult. The different canal system and very complicated according the tooth. So group 1, conventional treatment, no laser, complete isolation, remove cavity by accessing pulpal chamber with rumbar. Take the first microbiological study, instrumentation, conventional endomotor, use the different endomotors, but depend the clinical case or combination the endomotors or the comfort or the dentist, yes? And use the sodium hypochlorite, in this case, group 1, no laser, sodium hypochlorite 5.25%. And take the second microbiological study and use the different imaging, periapical X-ray. So endodontic material, this is in my clinic in Uruguay, is very personal. They prepare the table. I prepare 3 tables with all materials, and I like a lot. Yes, I like a lot different loop. Different loop is very important in endodontic. Yes, the endodontic materials. Sorry. Sexing. Group 1, yes, no laser. We take the first microbiological sample. The sample is taken to the with a sterile piping point. We impregnate the point inside the conduit and keep in an epinephrine tube of 2 milliliters with a saline solution 1x or PBS solution. Put the paper point in the conduit and put at the tube and the laboratory. Biomechanical preparation. We use in this case, the motor X-Mark Plus, the dense permaelafer, the files protein X, X1, X2, X3, and X4, and a speed of 200, see, very important, 250 or 300 RPM, and with the torque 2.4 and 2.6. We use the upper locator. It's prepared, yes, to assure the length of work. This is the endomotor, my hand, the file prepares different files. So we use this group 1, group 2, we use the radiovisiography, and the imaging and the apex locations. It's in Uruguay, yes. Starting negotiation of the canal with file 0.810 15 millimeter density. The file work on the two sutures of the tooth, so that we can see the canal is totally permeable. And the first file we enter with Pickerman movement of the length of work. Then, yes, then with the X2, X3, and X4, equal movement, the one, always recapitulation with the file 15 density. Irrigation with sodium hypochlorite at 5.25% and use the ADT8 17% in shell. In the slide, show the tube, the work, the two, the first microbiological sample. This is the future research, the pulp, and the second microbiological sample. Yes, the second microbiological sample. So we can clean with the saline solution and take the third sample with a paper point before drying the canal and fill it to be studied the laboratory and microbiological. And then when placed in the sterile tube, always taking care not contaminated. We use a 2 milliliter appender for tube with PBS saline solution 1X. We dry the canal with a sterile paper point. So finish filling back the gutta-cord, the dense ply, the length of work. We use different cement according to the clinical case combination or according the comfort the dentist. Serving of the satisfaction experience of the patient, prescribe the medical medication needed, control, X-ray, control after 1 month, 3 months, 6 months, and 1 year or more. Group 2, the treatment with laser, the same protocol than conventional treatment, but we use laser, different wavelength, and now use the sodium hypochlorite. Complete isolation, remove the cavity by a 16 pulper chamber with a round bar. Take the first microbiological sample, instrumentation, conventional endomotor, and use the different one-on-one and combination. 2,790 nanometers, 940 nanometer, and use the other laser, and use the 660 nanometer. This controversy in endodontic, yes, and with the PDT methylene blue 0.005%, and they use the saline solution. We take the microbiological sample and use the periapical X-rays. After accessing, we take the first microbiological sample in this group 2, the laser group. The sample is taken with a sterile paper point. We impregnate the point, yes, in the conduct and save in the Penderford tube of the 2 milliliter with a saline solution 1X or PBS solution. They put the paper point in the conduct and the tube and go into the laboratory. Yes, okay, so the laser system is very important. We use different wavelength or laser in the clinic on the research. Take the course or first take the course of the master and the university, different university in the world. For me, the Aachen University in Germany, for me, is the best in the world, but it's very personal. But for me, it's beautiful experience, and I need the cure the layering curve in this area, the laser. And we use in the endodontic, we use the clinical shape with the erbium chrome to 2790 nanometer, and it's very important calibration, the different calibration, the lasers, the dentist calibration, the parameters, and we use in clean shape tip R52 power 1.25 hertz 50 mode 8 earth 30 and water 50. And disinfection the canal, we use the tip, same tip, low, yes, 0.25 power. We use the hertz 20 mode 8 and air 10 and the water 1, according to the Aachen Dental Laser Center, according to Professor Norbert Gutner, the Aachen University, Germany. We use the gold handspace. For me, it is best the gold handspace in this treatment. Okay, this is show. We use 2,790 nanometers in the conduct. Yes, this is the show. It's very important, the glasses according to the laser in the clinic, when you laser in the clinical the patient. We use the other laser 900, very beautiful laser 940 nanometers, the diode laser, and use the endotip. Different tip, but in the endodontic use the 2,000 micrometer of diameter dish, the yellow tip. Show the tip, yes, different tip, the yellow and 2,000 micrometers. We do not need to initiate the tip in this laser, 940 nanometer, and use the glasses for the security. Use the power 1.1 and 1 watt in continuous way, according to Aachen Dental Laser Center, the Germany, for the yes, this laser 940 nanometer, the laser calibration, the parameter, the screen, and white top plate diode laser time 4.2 millimeters second for every canal, circle movement from apical to coronal within the root canal at the least to ISO 3040, and the power 1 watt continue according the nanometers, and the Aachen Dental Laser Center, the fiber adjust to root canal length. Yes, they show my clinic in other place in Uruguay, in Young, in this moment with my different, put the slide because very important, the glasses and the security and laser in the clinic and in the patient, the assistant, and in the child, it's beautiful child, and very comfortable with the glasses. And this is my sister, Eliana, work with me, different assistant on the patient. We use the diode laser, other diode laser, 660 nanometers, the Argil lasers, the Bilbao Spain, and we use the power 120 milliwatt, the energy 10 joules, 10 joules, the square centimeters, and time 60 seconds. So used in the photodynamic therapy with the methylene blue at the 0.01% with the 660 nanometers, and it's very important the dilute when using the tools, and the thoroughly after application we use in this moment. After laser application and with the saline solution, we take the first microbiological sample. The sample is taken with a sterile pipette point. We impregnate the point inside the root canal and keep in the epender tube of 2 milliliters with a saline solution, 1X or PBS solution. Always an endodontic is very important. Combination, the different evaluant is very important. Is more effective, yes, in the research and in the clinic. In the clinical study, show the tube, yes, the group 2, one tube, the future tube, the future pulp, and the other, take the second microbiological sample. The filling duct, the gutter cord, the dense ply in group 2. We use the gutter cord, the dense ply, the length of work. Yes, this is the laboratory with the work in this oral presentation. We use the Petri dishes, the microscope, laminar flow, cabinet, and laboratory material, and identify the presence of the pathogenic the bacteria, and focus the present or the bacteria or not present in the root canal. So this is the laminar flow cabinet, the different tube. Yes, studying in this moment in the laboratory in the Spain, a beautiful, and use the microscope, stereoscope, and microscan, autoscan for the Siemens. These bacteriological studies have been based in observing the presence or absence the bacteriological agent Streptococcus enterococcus fecalis, a facultative anaerobic bacterium, which is normally found in the human oral cavity from on the dental film, of course. These microorganisms are the main cause the development of bacterial contamination in the root canal. They produce a different problem and the fuelers in the endodontic. It lives in media with neutral pH around 7 and 8. So, yes, the list of samples include the conventional treatment, the patient codes, as follows: the patient code, different number, and the dish codes, and different tube. The laser group, yes, the samples, the patient codes are identified, and the dish code, and the different tube. The culture medium using the methyl salivarium, specific for isolation of the streptococcus. The referent strain of the streptococcus mutant, we see the referent, and the enterococcus fecalis use the referent. The seeding protocol use is a follow. Being a facultative anaerobic bacterium, the incubation takes place under condition of anaerobiosis at 37 Celsius degrees, yes, and for 48 hours of incubation. The dishes are read are 24 and 20 48 hours. The treatment is done at the clinic. Samples are taken from each patient. They're taken to the laboratory and started at the 4 Celsius degree for the test. Serial deletion of each of the samples are the 0.0, 0.01 and 0.001 in addition, and in dilute setting to carry out and the point cone and the cellulars of cultivate with which they perform the clinic of the endodontic canal. So this is the dish with growth of bacteria and this without growth of bacteria. Result. Obvious bacterial growth is observed in the mouth dishes corresponding to the sample that have not been treated with laser, and the sowing of microorganisms is carried out in beauty security company and making use the protocols of the laboratory norms. They show in the slide the dishes corresponding to the sample of the individual treatment with the laser and showing the absence of the bacterial growth. Oh yes, this is a beautiful graph. The beautiful graph, the laser group and the conventional show the no groove in the laser. Yes. The red and more in the conventional in this work. So this is graph the information the laboratory, and this in red the pain is very okay, and the swelling no swelling, and different result. This is a research study. Very comfortable when used the different combination in endodontic combination, the evaluant. Conclusion, discussion, importance of the contamination in the success of the treatment. Studies have shown that in case when a negative microbiological culture has been obtained from the root canal at the time of filling, there is 90-40% success rate. On the other hand, when the filling in the performance and the cultures are positive, the success rate is reduced to 64%, confirming previous studies showing in case the periapical lesion that failure of healing is more likely when the canal is filled in the presence of persistent infection. Laser application allow us to have more bacterial control in endodontic treatment than in conventional treatment versus sodium hypochlorite. The application of laser is a better and safer method, avoiding the uncomfortable application and sodium hypochlorite and the side effect of it. And for that, working in a minimal invasive way, and the post-operative is the better with the laser treatment. A lot of reference, of course, the GoodNet and the team. And our team, the GoodNet, the Germany, the Aachen Dental License Center, and the Aachen University Germany, and the Kinkler are papers. Thank you very much. Thank you for attention. Muchas gracias. This is my email, and another language, shukriya. I don't know a lot of, and thank you for watching. This is International Society for Laser Dentistry. I membership. This is the most beautiful society in the world. The different country, the Latin America, the Europe, and the Middle East. Yes, the Argentina, the Alejandro Steinman, the Iran. Yes, a lot of colleagues and friends. Grecia, Dimitris Straka, and the Pakistan. Yes, a lot of the Colombia. So my friends and colleagues in the laser, Professor Dr. Norbert Gutnet in Germany. This is picked the Rane France in Bulgarian Congress. And my friends and colleagues, my group in Uruguay, the group Dendodontic in Uruguay. Miguel Martins, the Portugal, is in Germany in the oral presentation. And Professor Dr. Alejandro Steinman, the Argentina, is my best friend and work a lot with Alejandro Steinman. Group, I showed the group the Mexico. Yes, Pilar Martin, Miguel Martins, Doctora Victoria Palazuelo de ALZ Mexico, ALZ Mexico. And this is in Bulgaria, the meeting in the Congress in Bulgaria in last years. Different colleagues, the Mexico, the Egypt, and the India, and the Argentina, Morocco. Other colleagues, my friends, the Egypt, in Bulgaria, with Alejandro Steinman and Pilar Martin, and the Aslaida de Colombia. My group, the team. Yes, is in the speak in World Dental Federation, the FDA, World Dental Federation, speaking the laser, Argentina, Mexico, and Uruguay. Different colleagues, the other country, the different parts of the world. Okay, thanks. This is Professor Norbert Gutnet. Professor Norbert Gutnet have a lot of students in the world. He's a very, very simple and good person. Around the world have a lot of students, Latin America and Europe and the Middle East. Yes. So I want to invite the dentists and the companies of laser to ESLD World Congress in Cairo, Egypt. Yes, from 2022 May 2021, next year, and organized by Dr. Joseph Sedgwick, is my friends and colleagues and team from Egypt. I have a lot of dentists, the Egypt, Ibrahim Samir, Marwa, Dr. Marwa, a lot of group. The Egypt is very, very, very nice. And team Olympic, the Egypt 2021. The God want always the God want, of course. Thank you very much for watching and for attention.
Thank you so much, ma'am. Thank you so much. And that was a beautiful presentation, ma'am, and some beautiful pictures that we could see there.
Thank you so much. Thank you so much
and
for your words, and grateful.
And we'll be starting with question, ma'am. This is the first question. How much percentage of disinfection can we expect with laser?
Please, I share the screen, please?
Sure, ma'am.
Share the screen. The questions, and when the doctor when the doctor, the name, the questions.
How much percentage of disinfection can we expect with laser? It's written in the comment section. Chat box.
One second, please. ¿Dónde está? Write please the question. How much percentage of the disinfection can we expect with laser? Is very important, the question. Yes, depend the clinical case, the different, the combination or no, the one well-went or more well-went is very specific. The question. Yes, depends a lot of the factors. Depends.
So there are
the disinfection, the laser, the laser disinfection. Yes, ¿cómo se dice 100%? 900%. Yes. Yes, because depend the doctor combination or not, the laser, the different laser, the clinical case, depend the chromophorus, depend a lot of steps in this question. Yes, it's very important. It's very important the question, but depend a lot of factor or tips.
Next question is which laser is best for disinfection? Best laser for disinfection.
Yes. Thank you for the questions. Very important. Yes. Not the best laser disinfection. For me and my experience and the curve in the laser, yes, the different wavelength, the more disinfection is when combination the different wavelengths. Yes, say 940 nanometer or 980 nanometers or 2790 nanometer or erbium or other erbium 2940 nanometer. The erbium jack is other. The combination in endodontic is the best laser. No use the one laser because yes, for me the combinations, the different wavelength.
So there's not just a single laser, but a combination that ma'am prefers. Next question, ma'am. Open apex cases, can we use laser?
Open apex cases. Yes, of course. Yes, of course. Sure.
Okay.
Sure. Because this area is very difficult. Yes, it's very difficult. infection, the bacteria, different microflora, and it's very important use the laser in the apex, in the open the apex. Yes, no problem, no problem.
So
But
those were
it's very important. The question is very interesting, very specific. The other topic.
Thank you, ma'am. Questions are done, and it was nice to have you. It was a beautiful presentation, and thank you so much.
Thank you so much for the expression from me, and thank you very much for the group collaborate and help the DRDC 2020 International Congress online. It's a pleasure for me. I'm very, very happy to collaborate with you and the team, work hard, and the communication. This communication is beautiful. The Uruguay from India. Thank you very much for invitation, and Kin many greetings, and Kin Rigel, and good day.
Have a nice
evening, because in Uruguay in this moment in the morning. Yes. Thank you very much, and the college and the audience, of course. Sure.
Thank you, ma'am.
Thank you.
So that was Dr. Carolina. Okay, so one more question is there now. It has come now. Can lateral and accessory canals be disinfected with laser? Well, we don't have Dr. Carolina with us now, but you surely can put up these questions. You can surely put up these questions. Her email ID is there mentioned on the app that you can download. You can put up the questions. You can send your questions directly to drdca2020@gmail.com, and we'll make sure that questions are answered. We'll try our best at least. So I think that is the beauty of digital platform, that no matter what country you are in, what language you speak, at least, we can try that much, that we can come together on a platform and share the knowledge, share the wisdom we have. Technical glitches will always be there. Language barrier will always be there. But these times will tell us how to overcome all of them. Now, Harry S. Truman said, it's what you learn after you know it all that counts. And to be honest, what I feel is we never know it all. So learning is a continuous process, and it goes on and goes on and goes on. Today, it was a wonderful session, one morning and one evening session with 4 speakers. Next, the session is on Thursday. It will be an evening session, and we have 2 speakers joining us, one from Argentina and one from India, Dr. Alejandro Steinman and Dr. Narayan. And the topic is very interesting. We are going to talk about immediate implants and the use of laser in the infected tissue, infected site when we are placing immediate implants, and whether lasers help or not help. So we'll be going to discuss about that. And meanwhile, you have 3 days. What you can do is register yourself. 2 days you have, take part in cultural competitions, send your entries, sing, dance, poetry, writing, whatever you do, try to win an award. And the third thing that you can do is participate in Novolace, participate in a lucky draw competition where you can get Novolace laser dental machine, this one. So I think, and then you can use these this machine, you can use the laser in patients also while doing root canal treatments. Okay. So what you need to do is download the app, register yourself for DRDC event, take part in competition, be active while asking questions, share the lives with your friends, tag your friends, spread the knowledge, and I think we can learn together and we can grow together. On that note, I'll take your leave, and I'll see you on Thursday at 5 p.m. Thank you.